Crimean-Congo Hemorrhagic Fever Virus. So, Crimean-Congo Hemorrhagic Fever Virus is positive of serious human hemorrhagic fever with mortality of around 30%. The range is between 5 to 50%. Crimean-Congo Hemorrhagic Fever is a zoonotic viral disease that is asymptomatic in infected animals but serious threat in humans. It is thought to be a home disease, with reports from Southeast Asia, Russia, and other parts of the world from the 12th century. The first documented outbreak of this disease was reported in 1944 to 1945 from the Crimean-Congo region of Soviet Union. The isolated agent, Crimean-Hemorrhagic Fever Virus, was indistinguishable from Congo virus, hence this isolated from a febrile patient in Congo in 1956, leading to the current designation Crimean-Congo Hemorrhagic Fever Virus. Here there are reports of the disease from more than 30 countries in Africa, Asia, Southeast Europe and Middle East. The virus is of importance due to the high fatality rate and high risk of nosocomial infection and potential use in viral history. During summer in 1944 to 1945, over 200 cases of acute hemorrhagic fever occurred in the Soviet troops, 3,128 cases of Crimean-Congo hemorrhagic fever, with 5% case fatality reports from Turkey between 2002 to 2008 was reported. September 2010 to 2000, there were around 100 cases reported from Pakistan and 10% fatality rate was shown. In 19 January 2011, first case of reported in Gujarat. In India, there were 4 deaths reporting with a doctor who was also involved in the death and a staff nurse. So in Gujarat, in January 19, 2011, there were 4 deaths, among 2 were medical professionals. In 2012 May, 71 cases were reported in Iran and 8 deaths were reported. So the morphology. Bunnyviridae was the family, genus is norovirus. The virus is enveloped with a tripartite single-stranded structure with negative-sense RNA. The genus is enveloped into 3 parts: the large segment, which is around 11 to 14.4 kb in length, which encodes for the RNA-dependent RNA polymerase; medium-sized segment 4.4 to 6.3 kb, which encodes for the envelope protein. The envelope protein is initially translated as glycoprotein precursor and then cleaves into 2 small proteins GN and GC. Small segment is around 1.7 to 2.1 kb in length and encodes for the nucleocapsid protein. The virion is around 80 to 120 nanometers in diameter and the pleomorphic. Each virus contains 3 copies of the genome. The envelope protein forms small projections around 5 to 10 nanometers in size. The nucleocapsid are filamentous and circular with a length of around 200 to 3000 nanometers. Based on the sequence data, 7 genotypes have been recommended, starting from Africa 1, 2, 3, Europe 1, 2, Asia and Asia 2. So this is the structures: the amino terminal, the carboxyl terminal, envelope, RNA dependent RNA polymerase, nucleocapsid and RNA segments. Vectors. Crimean-Congo hemorrhagic fever virus usually circulates between asymptomatic animals and ticks in the zoonotic cycle. The virus has been found at least in 31 species of ticks, including 7 genera, which includes the family Ixodidae, which is a hard tick. The principal vector is a Hyloma genus, Hyloma marginatum, and Hyloma anatolicum. Other genera of Ixodidae ticks include Rhipcephalus, Buphelus, and Dermacenter. 3 main types of transmission of the virus occur in ticks: transmembrane, transstadial, and venereal. The host. Many species of mammals can transmit Crimean-Congo hemorrhagic fever to ticks when they are viremic. Amplifying hosts are small vertebrates such as hares, hedgehogs, which are infested by immature ticks. With exception of ostriches, birds can be refractory to infection. However, migratory birds might spread the virus through the distant geographical area. So this is the life cycle. I think it is self-explanatory. So the primary season of transmission is spring and summer. Infectious doses around 1 to 10 organisms. Incubation period is 1 to 3 days following tick bite, and for the exposure of blood or tissue it takes around 5 to 6 days. Maximum of 13 days for blood and tissue related infection, and following tick bite, it is around 9 days for maximum. Transmission: direct contact with blood and infected products, aerosol, sticks, bites, crushes of infected bite with bare hands, drinking of unpasteurized milk. Possible horizontal transmission has been reported from mother to child. At-risk population: so the animal herders, livestock workers, veterinarians, aborters and farmers in endemic areas, healthcare workers, international travelers with contact to livestock in pathogenesis. Cell surface receptor nucleon. The viral glycoprotein is responsible for the recognition of the receptor sites on susceptible cells. Following the attachment, the viruses are internalized by endocytosis. Then replication occurs in cytoplasm, and the virions mature by budding through the endoplasmic reticulum into the cytoplasmic vesicles in the Golgi region. Binding virus is also known to bud from Golgi membranes, and budding site seems to be defined by retention of glycoprotein GN and GC. GN means Golgi compartment and GC is from the endoplasmic reticulum. Recently, the expression strategy of and biosynthesis of Crimean-Congo Hemorrhagic Fever glycoprotein has been studied in detail. The substance SK1 has been identified the cellular protease responsible for the processing step that generates the amino terminal of mature GN. Regions containing the ovarian tumor like cystine, protease and helicase domains were identified in the L segments of Crimean-Congo Hemorrhagic Fever, suggesting the autoproteolytic cleavage processing for norovirus L. So the third one was not spleen, it was adrenal gland. Okay. The clinical features: the pre-hemorrhagic phase around 3 to 6 days, sudden attack of fever with chills, headache, photophobia, neck pain, dizziness, myalgia, abdominal pain, diarrhea, vomiting, hypotension, neuropsychiatric changes like early mood swings, confusion, aggregation of anger, and so on. Later is sleepiness, depression, and lassitude, tachycardia, and nephrotinopathy. Second is the hemorrhagic phase, which occurs around 2 to 3 days. It begins on the third or fifth day of the petechiae with ecchymosis, hematemesis, epistaxis, melena, leukopenia, thrombocytopenia, and hematuria. The complication of hepatorenal syndrome, pulmonary failure, and DEC. Mortality is second week and ranging from around 5 to 50%. Convalescence. Improvement starts around 9 to 10 days. Pronounced generalized weakness, weak pulse, sometimes complete loss of hair is seen. Sequel: polyneurosis, headache, nausea, poor vision, hearing loss, memory loss. Clearly, these changes may be permanent, but they may persist for 1 year or so. Case definition: a patient with abrupt onset of fever more than 38.5 degrees Celsius and one of the following symptoms like headache, myalgia, nausea, vomiting, diarrhea, and history of tick bite within 14 days prior to the onset of symptoms, or history of contact with tissue, blood, or biological fluids from a possibly infected animal, that is abattoir workers, livestock workers, and veterinarians within 14 days of the onset of the symptoms, or healthcare worker in a healthcare facility with history of exposure to a suspect probably or a laboratory confirmed Crimean-Congo Hemorrhagic Fever case within 14 days prior to the onset of the symptoms. A probable case. A probable case is defined as a suspect case fulfilling the additional following criteria like thrombocytopenia less than 50,000 and 2 or more hemorrhagic manifestations like hematoma and injection site, petechiae, purpuric rashes, rhinorrhea, hematemesis, hemoptysis, gastrointestinal hemorrhage, gingival hemorrhage, and other hemorrhagic manifestation in the absence of known precipitating factor of hemorrhagic manifestation. A confirmed case. A confirmed case is defined as a case that fulfills the criteria of probable Crimean-Congo Hemorrhagic Fever, and in addition to the laboratory confirmed with one of the following assays, that is by detection of ELISA or immunofluorescence assay of specific IgM antibodies against this virus, and a 4-fold increase in the specific IgG antibodies against Crimean-Congo Hemorrhagic Fever virus in 2 specimens collected in acute and convalescence phase. Detection of RT-PCR of Crimean-Congo Hemorrhagic Fever genome is critical in a clinical sample and confirmed by the product. Isolation of this virus. Diagnosis: serum, plasma, or tissue like lung, liver, spleen, bone marrow, kidney, and brain Handling of the samples requires biosafety level 4. Serology is also used, like IgM and IgG detection by ELISA, and immunofluorescence test. Viral genome detection by using RT-PCR is most sensitive. Antigen detection using immunohistochemical staining, and isolation of the virus by cell culture and inoculation into newborn viruses. So serology we have already discussed, so I don't think I have to go in detail. Just go through these slides. So treatment part. General support treatment is the mainstay of the management. Intensive monitoring to guide the blood volume and replacement is required. The antiviral ribavirin is used in the treatment of established condition. Both oral and IV formulation seem to be effective. Passive immunotherapy with hyperimmune serum has been tested in few cases. A new specific IG Crimean-Congo Hemorrhagic Fever Virus has been prepared using the pooled plasma booster donors. It contains antibody to Crimean-Congo Hemorrhagic Fever in a titer of 8. Treatment protocols for adults with Crimean-Congo Hemorrhagic Fever gives 2 gram loading dose of ribavirin followed by 4 gram per day in 4 divided doses 6 hourly for around 4 days. 2 gram per day, 4 divided doses for 6 days. So this is the dosage recommendation. And in children, the table column gives the information. So IV to 17 mg per kilogram on day 1, and from day 1 to 4 17 mg per kg 6th hourly, and from day 5 to 10 8 mg per kg 8th hourly. So oral formulations are given at 30 mg per kg on day 1 and 15 mg per kg on day 1 to 4 6th hourly, and 7 mg per kg 6th hourly given from day 5 to day 10. Prevention vaccines. An inactivated mouse brain derived vaccine against this virus has been developed and used on small scale. There is no space or safe effective vaccine available currently for human use. Use of chemical intent to kill the ticks is good. Insect repellents containing DEET can be used. Wearing protective clothes helps. For healthcare workers, universal precaution including barrier precautions and nursing while dealing with cases of Crimean-Congo Hemorrhagic Fever should be done. Healthcare workers who are in contact with the tissue or blood with the patient with suspected or confirmed cases of Crimean-Congo Hemorrhagic Fever should follow with the daily temperature and symptom monitoring at least 14 days after the exposure. Disinfectant. This virus can be inactivated by 1% hypochlorite solution, 2% glutaraldehyde, or boiling at 56 degrees Celsius. Thank you, students. I am very happy to present this. This lecture took around 22 hours to prepare. I referred 20 books, so I think this lecture will help. And even if I get one view for this, I'm happy that one student got benefited. Thank you so much. God bless you. Thank you.